Greetings of the day, folks. Today we are going to discuss about the due criteria for infective endocarditis, the diagnostic criteria for endocarditis. So, when do you use that? So, you have to suspect infective endocarditis and consider due criteria in the following patients. If the patient has got a prolonged fever, fever of unknown origin, and fever and vascular phenomenon may include the embolus going to CNS causing stroke or to a limb causing ischemia or any physical findings of septic emboli, and in persistently positive blood culture 2 or more, prosthetic valves who are febrile, uh, and injection drug users who are febrile, and predisposing heart condition who are febrile, fever with a recent history of hospitalization. So let us dive into the criteria. So the creator is Dr. David Durack. So it does not fit, right? Due criteria, Dr. David Durack. So let us see. So what is this? Who is this Dr. David? So David Durack, MD, is an infectious disease specialist. He was affiliated to Duke University. So now we get right. So where the name comes from, Duke University. So Duke criteria. So when the what are the pulse? It is a formal criteria to diagnose and stratify patients suspected of having infective endocarditis into definite, possible, or rejected. It should be applied to patients in whom there is high clinical suspicion of infective endocarditis. And negative cultures may be confounded by a recent history of treatment with antibiotics. And also, once patient is diagnosed with infective endocarditis, there is a mortality risk score that can help risk stratify a patient's 6 months outcome once IE is confirmed. And why do you use this? So patients with IE have a infective endocarditis have a wide range of clinical features and diagnosis can be challenging. This criteria is sensitive for disease infection of disease detection and how it has got a high negative predictive value. That means if it is negative, then most likely patient does not have any infective endocarditis. Okay. So if you see this, there is pathological criteria, major clinical criteria, and minor clinical criteria. So totally three major divisions. So if either of this, see here, this is the result we get after clicking on this. So if either of this, that is microorganisms or vegetation or a pathological lesion, if either is positive, then diagnosis is definite. Okay, so what are the microorganisms like demonstrated by culture or either like culture or by histological examination of a vegetation that embolized or intracardiac abscess specimen. So after taking that, if there is histological confirmation of a microorganism or a pathological lesion, like vegetation or intracardiac abscess confirmed by histological examination showing active endocarditis. See, if I click on this, then the result will be the diagnosis is definite, right? So and if I click this, so it is also a definite because we are confirming that there is infective endocarditis. So the other ones are the major clinical criteria. It is major. So here also we are having the main things. So here we require both to be positive for diagnosis to be definite. See, the blood culture is positive for endocarditis and evidence of endocardial involvement. So typical organisms consistent with infective endocarditis from two separate blood cultures or and also microorganisms consistent with infective endocarditis from persistently positive blood culture, single positive blood culture for Coxiella burnetii or antiphase IgG antibody titer more than 1 is to 800. And for evidence of endocardial involvement, echocardiogram positive for infective endocarditis, abscess, no partial dehiscence of prosthetic valve, new valvular regurgitation, and see if there is a pre-existing murmur or worsening of the murmur which was not there prior to that. So if you see this, if I click on single one, it will be rejected. So it is down diagnostic. If I click on both these things, so it is definite. So the patient is definite for the diagnosis of infection. Now here the minor criteria are if all are positive, then diagnosis is definite. If see the conditions are like the criteria are predisposing heart conditions or injection, drug abuser, fever, vascular phenomenon, which includes major arterial emboli, septic pulmonary infarcts, myocardic aneurysm, intracranial hemorrhage, conjunctival hemorrhages, and Janeway lesions, and immunologic phenomenon like glomerulonephritis, osteomas, rot spots, and rheumatoid factor. and micrological evidence like positive blood culture that but does not meet a major criterion as noted above, or serological evidence of active infection with the organism consistent with infective endocarditis. Okay, if you click 4 out of 5, it won't be, it will be coming to it that it is possible, not a definite. Okay, see this. So 2 or more is like 2, more than 2 is considered as possible, and 5 out of 5 of the minor criteria is diagnostic is definite. Okay, so this is the infective endocarditis, and we'll see what is our advice. We will so after the knowing that the patient is definite or possible or rejected, what should be this one. So in definitive, if the patient is definitely diagnosed as having infective endocarditis, then we'll start the empiric antibiotic treatment based on guidelines and microbiology, and we should identify the candidates who will require surgery, and also possible. In case of possible clause, we should use the clinical judgment whether the patient like definitely has or possibly has infected endocarditis. And in these conditions, we may consider transesophageal echocardiography. And if not done, identify, and we also need to identify persons who might be eligible for surgeries, and also examine the patient regularly for major or minor signs, and examine for physical conditions, findings such as rod spots, also not genital lesions. And we need to identify the draw blood cultures. Okay, if the patient is rejected, then we have to consider for other causes. Okay, so in management, definitive is one or more pathological criteria, two major and one major, or three minor. Okay, five minor. This is definite infected, and possible is one major and one minor, three minor. Okay, and in rejected, firm alternative diagnosis for explaining the evidence. Okay, and resolution of IE symptoms with antibiotics for less than or equal to 4 days, it might be rejected. Okay, and no more pathological evidence of IE at surgery or autopsy with antibiotic therapy less than 4 days, and it does not meet the criteria of possible as above. And in case of like critical action prior to treatment with even a few days of antibiotic may mask the pathological evidence. Okay, so consider transesophageal echocardiography if clinical suspicion is high. Thank you.